Yes, sir.
You are presenting first. Okay.
Yes, sir.
Just get ready with your share that options.
Yes.
Dr.
Good
Bharat
evening,
is
friends.
Bharat is my assistant, sir. He's actually a very senior person. So
Yes, sir.
he's another faculty I'm introducing now in this
Yes,
forum.
sir. Yes, sir.
So
Thank you, sir.
Give me a minute, Dr. Rajgopal, for just a moment.
Yes, sir.
Can you switch on your video first?
Yes, sir.
For some reason, we are unable to see you.
Yes, sir.
yes.
Oh,
Yeah,
good.
we can see him. Yes.
For a moment, please wait.
Yes,
Good
sir.
evening, friends. We warmly welcome the invited faculty and our own faculty for this edition of the postgraduate clinics. Friends, we are reverting back to yet another newer format now. One short case and one long case as proposed by the senior faculty here. We will consider this format for another 3-4 weeks and then we'll take a call. Because all of us felt one case will be a little short for every one of us. So we have two important exam cases. One is a case of oral cancer and the other one is a obstructive jaundice, both contributed by Kasturba Medical College postgraduates with the kind permission of the professors and the head of the department. So we warmly welcome Professor Kaustubh Patel. Professor Kaustubh Patel is an exclusive head and neck oncology surgeon. He right now is in the HCG group of Ahmedabad. From the beginning, he has been helpful, and he said any head and neck cancer, he'll be able to chip in. And in spite of giving a short notice, sir was kind enough to consider to join. We have Professor Bharat from the Department of Surgery at the Kasturba Medical College. Warmly welcome, Professor Bharat, sir.
Yes, sir. Thank you, sir.
And we have Professor Kalayarasan, Professor Sharvari, and Professor Hidyanag from GB Pant Hospital coming up for the second case. And we also could see a lot of eminent faculty here. Dr. Rajesh Sahai, sir, Dr. Nishikant, sir, and we have Professor Gabriel Rodriguez. Thank you, Dr. Gabriel, sir, for joining this evening. And we have other senior professors.
Thank you, sir. Thank you.
Thank you, sir. Thanks for joining and making time for this evening. And friends, this format, the first short case will be somewhere around 30 to 45 minutes and then move on to the long case. That's the plan for this coming 2-3 weeks. So, Dr. Rajgopal, you will be presenting the history without the halt, and then the examiners will revisit and ask questions based on it. And then you will run through the clinical finding, and later you go on to the management part of it.
Yes, sir.
Please introduce yourself, your unit chief, your head of the department, and start your presentation. Kaustubh sir and other faculty, invited faculty, please take over. Good luck to you, Dr. Rajgopal.
Thank you, sir. Good evening, sir. This is Dr. Rajgopal, third year postgraduate from Kasturba Medical College. And my professor is Dr. Rajgopal Shenai. And I'll be presenting my short case, sir.
Can you make it a slideshow, please?
Yes, sir.
Please do it. Yeah. Thank you. Slideshow. Yes. Slideshow.
Yes, sir.
Not yet. Possible do it there, no? Top there.
Yes, sir. Yes, sir. Done, sir.
Done?
Done, sir.
Mm.
Is it visible, sir?
Okay. Slides are
it is visible, but it's not in the slideshow mode. This is a PPT mode, so
Yes,
you need to project it in a slideshow mode.
Yes, sir. I projected in the
Dr.
slideshow.
Rajgopal, please unshare this for a moment.
Yes, sir.
Right.
Yes.
Now, press the share button. I'll tell you which one to click.
Yes, sir.
Right. What are the windows you are able to see now?
Windows, CA alveolus, the PowerPoint slide.
The PowerPoint slides you press now?
Yes, sir.
Okay. You, on the downside, If you
Yes.
see, there is a screen type of thing, the last lowest button.
Yeah,
Can you
now-
see that? Below that, next to that, left, little left of that, left. Ah, yes. No, you crossed one.
Yeah, that's
Yes,
fine.
there you go. Good luck, team.
Yes, sir.
You can start.
Yes, sir. Presenting complaints. A 75-year-old male, a shopkeeper by occupation, hailing from Karkala, Karnataka, came with complaints of swelling over the inner aspect of left cheek and gums since 2 months with ulceration, pain since 2 months, loosening of left upper teeth since 2 months, history of presenting illness. The patient was apparently normal 2 months ago when he noticed a swelling over the inner side of the left cheek and gums, which was insidious in onset, progressive in nature. Initially, the swelling was about 2 cross 1 centimeter in size and progressed to the current size of 4 by 2 centimeter. The swelling was associated with pain, which is a throbbing type of pain, intermittent and radiating to the left side of the face and aggravated by chewing food. History of loosening of left upper teeth 2 months ago. The patient had visited a local dentist for the above mentioned complaints and dental extraction was done, following which the pain and bleeding had increased over the swelling and there was discharge from the tooth socket. He was initially managed conservatively with antibiotics and was referred to the Department of Oral Medicine, Kasturba Medical College for further management. The patient had complaints of difficulty in chewing food due to pain. History of dental caries 1 year ago, for which tooth extraction was done and the sockets had healed. History of brown color staining of tooth. History of pain over the left ear. No history of difficulty in swallowing. No history of excessive salivation. No history of difficulty in speaking. No history of any alteration of voice. No history of any other swelling noted over the neck. Um, Patient had history of consumption of pan since past 15 years. He consumes it twice a day after every meal, and he chews it for 5 minutes and spits it. He had stopped it 2 months ago after the swelling and pain had started. Past history: the patient is a known case of hypertension since 15 years on oral antihypertensive medications. He's a known diabetic since 6 years on medication. Known CKD since 1 year. So not a known case of CAD, CVA, and bronchial asthma. No history of any previous surgeries. No history of similar illness among other family members. Personal history: he has a mixed diet. No history of smoking. No history of alcohol consumption, and no history of high risk sexual behavior. Summary. Shall I summarize the history, sir?
Yes, please.
Yes, sir. A 75-year-old male with complaints of swelling over the inner aspect of the cheek and gums with ulceration since 2 months, pain since 2 months, and loosening of left upper teeth since 2 months, and history of consumption of pan since 15 years, and known diabetic and hypertensive and CKD. The likely diagnosis is a malignant swelling.
So, Rajgopal,
Yes, sir.
yeah, was the pain first or the swelling first? And do you think it has any importance?
The swelling first, sir.
Right. So, what is the difference in your mind when you are thinking about these patients for the diagnosis? When the pain first or the swelling first? What is the difference in your inferences? Because see, in your history, everything starts at 2 months,
Yes, sir.
right? Everything is at 2 months.
Yes, sir.
In a malignancy,
Yes, sir.
usually the swelling starts first and the pain comes later.
Yes, sir.
Okay, pain
Yes.
is when it is a pain first and swelling later, it is usually infective etiology. So in whenever there is these kind of swellings, you must elaborate whether the pain was first or the swelling was first,
Yes, sir.
right?
Yes, sir.
And another thing which I could see was you had said that there was a loosening of the teeth,
Yes, sir.
right?
Yes, sir.
So this tooth was extracted, or it fell off, or it is still there.
It was extracted, sir.
So do you think it was the right thing to do?
No, sir. The dentist at that time was probably not suspecting a malignancy, so he might have done a tooth extraction, sir.
Right. So what he would have done to know before extracting this tooth? What he should have done?
He should have inquired about the patient's history of uh, uh, tobacco chewing and
Right. So,
yes, sir.
tobacco chewing, uh, the swelling first and then pain, and then he should have taken an X-ray which could have shown the erosion,
Yes, sir.
and it would have made him understand that this is not a infective loosening of the teeth.
Yes, sir.
Extracting these teeth will open up the channels for the cancer to grow fast, go inside the sinus,
Yes, sir.
right?
Yes, sir.
Okay. Second thing, I could not see a word of tobacco in that pan material which you elaborated. Can you go to that slide?
Yes, sir.
Betel leaf, areca nut, slacked lime,
Yes, sir.
but there is no tobacco.
Yes, sir. I inquired about it specifically. Did he chew tobacco? And he told that he had taken only these things, sir.
So, what do you think? Uh, there is no tobacco history. Why he developed this cancer?
Probably due to chronic irritation, sir.
Areca nut is equally important carcinogenic material compared to tobacco.
Yes, sir.
Okay, the betel nut or areca nut, which we call
Yes, sir.
supari, which we call, is an equally important carcinogen.
Yes, sir.
Okay, yeah. Let's go ahead now.
Yeah, no, sir, Dr. Rajgopal, could you go to your first slide?
Yes, sir.
There are a lot of things which are missing, which I want to make. Look, by your history, I'm not sure whether it's the lower jaw involved or is the upper jaw. You've not mentioned anywhere which jaw is involved. It's just left cheek and gums.
Yes, sir.
So what am I supposed to expect?
Um,
All through your slide, I don't have
yes.
a picture of where is it the lower jaw, is it the upper jaw,
Yes,
is
sir.
it the buccal thing? Okay.
Upper jaw, sir.
Yeah, so actually should be because there's a difference. There's
Yes,
going
sir.
to be a difference in management
Yes, sir.
in everything, right?
Yes,
Okay,
sir.
let's go to your next slide. Look, if there is any growth in the oral cavity,
Yes, sir.
we want to know if the speech was normal, if he was able to deglutate normally,
Yes, sir.
swallowing, whether there was any drooling, whether he
Sir,
can.
yes, sir. I have mentioned that there is
Okay,
no.
mentioned it.
Yes, sir.
Right.
There is
But
no
what about
difficulty in speaking.
okay?
And,
But okay, that's why I probably missed it then. So
yes.
he has difficulty in chewing food, difficulty in
Yes.
swallowing, no history of difficulty in swallowing,
Yes, sir.
and no excessive salivation, which is
Yes.
unlikely. If he's got a growth in the oral cavity,
Yes, sir.
there's got to be some irritation sometime, and there'll
Yes,
be
sir.
excessive salivation,
Yes, sir.
right? So
Yes.
if you once you get this thing, either you ask a direct question, right?
Yes, sir.
And now he's had extraction of the upper and the lower teeth, only the
Yes,
upper teeth.
sir.
Both,
The lower teeth was extracted 1 year ago for dental caries. The
right?
recent he had underwent extraction of the left upper teeth, sir.
Okay.
Which developed after the swelling, sir.
Okay. Next, just go back to your previous slide.
Yes, sir.
Now, another thing which you're missing is the mouth opening sufficient? Was there any difference in mouth opening? Just
No,
go to your
sir.
previous slide. Next slide. Next slide. No, I'm sorry, previous. The one which saying no. Yeah. Yeah, you missed that slide. That one no. So is there? I can't see that difficulty in opening of mouth. Is there any change in there?
He did not have any difficulty in opening mouth, sir.
Okay. you must realize that the oral cavity has certain functions.
Yes, sir.
One is that to chew to take the food, to chew it, to swallow it,
Yes, sir.
to bring the tongue out, to speak,
Yes, sir.
right?
Yes, sir.
So all these have to be elicited very clearly.
Yes, sir.
Okay, next slide, please. Now, does he have any swelling other than on the oral cavity? Have you asked for any swellings in the neck?
Yes, sir. I have inquired about did he have any swellings in the neck, and he told he
Okay,
did
no
not.
history of swelling, so
Yes.
anywhere over the neck. Okay, next slide. Okay. Now, also, I would like to know whether, because so many times these malignancies, they go into the oral cavity or the aerodigestive system, right? So the patient can have recurrent history of pneumonitis, right?
Yes, sir.
All that has to come.
Yes, sir. Yes, sir. He did not have any complaints of cough or
Okay.
chronic.
Now he's chewing pan
Yes, sir.
twice a day
Yes, sir.
for 5 minutes for 15 years,
Yes, sir.
and he spits it out after 5 minutes. Why does he
Yes.
do that?
He
Why
does
does he
not.
do that? Because did he start doing this recently, or was it doing it since last 15 years? Because usually when people take pan, they keep it
Yes.
there for hours together.
Yes, sir. I had inquired whether he keeps it in the side in the gingival sulcus.
Right.
He did denied it, sir. He did
Yeah,
not.
this is quite unusual. It's unusual, right? Okay. No alcohol, no smoking.
Yes, sir. No alcohol, no smoke.
What did he work as?
He's a shopkeeper by occupation, sir.
What kind of shop does he have? Any chemicals? Any what kind of shop does he have?
General store. He was running a general store. Sir.
So what's your biohistory? What's your diagnosis now? What do you think
Based
you're
on
dealing with?
history, the swelling is a malignant swelling in the left upper jaw on the left side, probably malignant swelling.
Okay. So please. Anyway. Should we go to okay, let's go to the examination. Can you go to the examination?
Yes, sir. General examination. After taking informed consent from the patient, examined in a well-lit room with adequate exposure. Patient is conscious, oriented to time, place, and person. He is well cooperative, moderately built and nourished to the BMI of 24. The ECOG score was 0. There was no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, or pedal edema. Local examination of the
Do you have a
local.
picture, Dr. Rajgopal?
Yes, sir. I have a picture, sir.
Let's show the picture first.
Yes.
Okay. Anything else? Any other picture? No.
Yes, sir.
Okay.
Yes.
Yeah, go back. Continue, please.
No facial asymmetry noted. Mouth opening was adequate, 4 centimeter. Halitosis was noted. There was no pooling of saliva noted. Loss of dentition of left upper teeth and right lower teeth given by the dental formula. There is brownish staining of teeth noted. Inspection intraorally, ulcerative growth noted in the left upper alveolus. Extent, it was medially extending up to the lateral incisor, laterally up to the region of the third molar, and anteriorly up to the gingivolabial sulcus, and posteriorly up to the hard palate. It measured around 4 by 2 centimeter. It was irregular shaped, edges were everted, floor was with slough, and discharge, there was a scanty foul smelling discharge, and the surrounding areas appeared normal. Rest of the oral cavity, the lips, the tongue, the gingivobuccal sulcus, hard and soft palate, floor of mouth, retromandibular trigone, and uvula appeared normal.
Rajgopal,
Yes, sir.
go back to your slide.
Yes, sir.
Back. Yeah. So one most important thing which you miss is whether this growth is crossing midline or not.
Yes, sir.
You
The growth.
have to mention this when you do examination, and
Yes,
when
sir.
you do palpation, you also have to mention at that time, because submucosally the growth can cross the midline, but ulcer may not cross. So an inspection, you must mention that whether the growth is extending to midline or crossing midline. The
Yes.
second thing is your nomenclature of medially up to lateral incisor is wrong. Medially is the midline.
Yes, sir.
Anteriorly and laterally are the teeth boundaries, and
Yes.
posteriorly is the soft palate boundaries, because this is probably a hard palate area
Yes,
growth,
sir.
and the soft palate is free. I can't see because of the shadow, but if
Yes.
it extends to soft palate, then you should say that posteriorly it extends to soft palate also. So
Yes.
it is medial boundary is midline for
Yes.
this value.
Yes,
Okay.
sir.
Yeah.
Yes, sir. Inspection of outer aspect of the swelling over the malar region. Diffuse swelling noted over the left malar prominence. The surface of the swelling appears smooth. The borders are not well defined, and overlying skin over the swelling appears normal. Palpation of intraoral aspect. Palpation of the ulcerative growth. The growth is not warm, non-tender. It is firm to hard in consistency. Inspectory findings of size, shape, and extent are confirmed. Margins are irregular and indurated. Base is formed by bone maxilla, and surrounding areas are normal. And palpation of the rest of the oral cavity is normal.
So
Palpation.
here, so here in palpation, you should also say that the tumor is submucosally extending or not.
Yes, sir.
Okay?
Yes.
At edges of the tumor, edges of
Yes.
the ulcer, right?
Yes, sir. Yes, sir.
Okay.
Gopal,
Yes, sir.
you are not mentioned about mouth opening.
Sir, I have mentioned mouth opening initially, sir.
Okay, okay.
Yes, sir. 4
Yeah, it
centimeters.
was 4 centimeter, I think.
Yes, sir.
Okay, okay.
Yeah.
Yes. Palpation of outer aspect of the swelling over the malar region. Swelling is not warm, tender. Uh, it's, a, it's a size of around 4 by 3 centimeter. Extent anteriorly 1 centimeter behind the ala of the nose. Posteriorly 2 centimeter in front of tragus of the ear. Superiorly 2 centimeter below the infraorbital margin, and inferiorly till the level of the angle of the mouth. Surface of the swelling feels smooth. Borders are well defined and regular. Consistency, it is bony hard in consistency and immobile. The swelling is not fixed to the overlying skin or subcutaneous tissue. Plane of the swelling, it is deep to the subcutaneous tissue and muscle, and the surrounding skin is normal. Examination of the mandible.
How will you, Rajgopal, how will you differentiate
Yes, sir.
the swelling, whether it is deep to subcutaneous tissue or it is deep to muscle? How will you define that this is deep to muscle and not involving muscle?
Sir, the swelling is cannot be moved at all, sir. It is bony hard in consistency. It is fixed to the bone, sir.
No, you said that the plane of swelling is deep to subcutaneous tissue and muscle, right?
Yes, sir. Yes,
That
sir.
means it is deep to muscle.
Yes, sir. Deep to muscle, sir.
So how will you elucidate that whether it is deep to muscle or not? Which are the muscles here
Yeah.
we are
Which are the
talking
muscles?
about?
GP number के
Sir, that might be buccinator muscle might be there, sir, and
So you understand that here are the muscles of facial expression.
yes, sir, muscles of facial
Okay.
expression. Yes, sir.
Now they are zygomaticus major, minor, buccinator.
Yes, sir.
There will be a posteriorly there will be masseter, though it
Yes.
will be a little away, but
Yes, sir.
that can be the muscle. Now all these muscles movements you can elucidate by
Yes, sir.
asking the patient to smile, asking the patient to show his teeth,
Yes.
asking him to hard
Yes, sir. Puff cheek.
close his eyes and all, so that you will know whether those muscles are involved or not. If they are
Yes.
involved, there will be a asymmetry between both the sides.
Yes,
Okay.
sir. Yes, sir.
The tumor has infiltrated the muscle or not.
Pardon,
Okay.
sir.
So that is the way you will elucidate whether the muscles are involved or not.
Yes, sir. Yes, sir.
Okay. Yeah.
Yes.
Go ahead.
Examination of mandible. There is no mandibular thickening noted. Examination of the neck. No regional lymph nodes are enlarged. Systemic examination. Cardiovascular system is normal. Respiratory system is normal, and abdomen examination of the abdomen appears to be normal. Provisional diagnosis. The carcinoma of alveolus and hard palate. T4A N0MX.
So Rajgopal,
Yes, sir.
I will say that you have not examined the neck.
Sorry, sir.
You have not examined the neck, right? How can you say it is N0?
Sir, examination of neck was done, sir.
Which slide? Okay, no regional lymph nodes enlarged. Okay,
Yes,
right.
sir.
I missed it. Okay, fine. Yeah.
Yes, sir.
Why you say T4A?
Sir, T4A because the lesion was extending into the cortical bone maxilla, which is the maxilla, sir.
How you could know that?
Uh, Sir, because there was a bony hard swelling palpable on the left malar prominence.
There is one important sign which you should try to elucidate is the sensation over the
Yes,
malar
sir.
region.
Yes, sir. Yes, sir.
Okay?
Yes, sir. Hypoesthesia over the malar.
Yes. So that I don't find in your presentation, which is an important sign you should elucidate, so
Yes, sir.
that you will know whether how these sensations are carried
The
out. Which
maxillary
now,
nerve, the maxillary nerve, which is a branch of a trigeminal nerve, passes through the sinus, and so in case there is a lesion within the maxillary sinus, the nerve may be involved, sir. Maxillary nerve
which
may
is
be.
infraorbital nerve, which goes through the maxilla and comes up on the anterior wall of maxilla.
Yes, sir.
Okay, that infraorbital nerve carries the sensation of these area, pre-maxillary area
Yes.
from the skin.
Yes, sir.
So that is one sign which will tell you without getting the X-rays or CT scan that whether the sinus and the bone are involved or not.
Yes, sir.
Okay. If it is positive, if it is negative, still there can be involvement of bone. But if
Yes.
it is positive, that means that the bone is involved.
Yes, sir.
Okay. Yeah.
Yes.
Please go ahead.
Uh, for further management of the patient, I will do routine blood investigations. I will do a CT of head and neck, and I will do a CT thorax
No,
for.
Dr. Rajgopal, sorry.
Yes, sir.
First you have to confirm your diagnosis.
Yes, sir.
Then you have to the investigations to confirm your diagnosis to know the extent of disease, and then
Yes, sir.
the condition of the patient. Okay.
Yes, sir. Yes, sir. I will do a edge wedge biopsy from the lesion to confirm the diagnosis, sir.
Why you will do an incision biopsy? Why can't you do a punch biopsy?
Sir, the lesion is more easily accessible, so I can do a edge wedge biopsy, sir.
You can do a punch biopsy, which is an office procedure.
Yes, sir.
No, intraorally, you can just examine, take a punch.
Sir, by edge wedge biopsy, I will take the lesion and the surrounding tissue, and which is better, sir.
So, Rajgopal, that is a classical teaching that you should include the surrounding
Yes,
normal mucosa.
yes, sir.
Now, in today's time, it is the tumor representative tissue which you need to take. You should not try and violate the margins of the tumor as far as possible. So,
Yes, sir.
only in the verrucoid growths, you need to take that. Otherwise, in these kind of frank malignant growth, what you need is a tumor tissue.
Yes, sir.
Don't violate the margins.
Yes, sir.
Okay. Yeah.
Yes.
Okay. What will happen if patient starts bleeding in when you do this biopsy?
Sir, I can give a compression. I can uh, sir, it will usually stop with compression, sir.
Extremely important before taking any biopsy from anywhere, that whether patient is taking any blood thinner or not.
Yes, sir.
Okay?
Yes, sir.
Whenever you do a biopsy, the first thing you should ask the patient whether he is on any blood thinner or not.
Yes, sir.
Okay? If he is on a clopidogrel, you have to ask him to stop it. You have to talk to his cardiologist and then take a biopsy.
Yes, sir.
Okay? Yeah.
HRCT of head and neck and PNS. A well-defined soft tissue lesion measuring 4.8 cross
Go back
4.7.
go back to the images.
Yes, sir.
Tell me which are the walls of maxilla involved?
Sir, the anterolateral wall, sir. The
Okay.
anterolateral wall is breached here, sir, and it is
Okay.
extending up to the subcutaneous plane, sir, here.
No, I'm asking about which are the maxillary walls involved. One is anterolateral.
Yes, sir. Anterolateral wall.
Then
The inferior wall is involved, sir.
yes.
The
Okay.
medial wall is breached, sir.
Right.
Medial wall is breached, and also the posterolateral wall is suspiciously eroding into the posterolateral wall, sir.
Okay.
Yes,
Fine.
sir.
Very nice. Go ahead.
CT thorax, there is no significant intrathoracic parenchymal abnormality noted in the present study. Incisional biopsy report. The final diagnosis is left upper alveolus squamous cell carcinoma, which is moderately differentiated. Final diagnosis would be squamous cell carcinoma of left upper alveolus T4A M0 M0. Sir.
So with that anterior wall, medial wall, inferior wall, anterolateral wall involvement,
Yes, sir.
the sensation on that malar region, the premaxillary region, were 100% lost in this patient. If you could have elucidated that, that would
Yes.
have clinched your diagnosis on the clinical examination itself,
Yes,
right?
sir. Yes, sir.
Okay. Yeah. So, what would be your next step?
Sir, I would present this patient to the multidisciplinary tumor board, sir, uh,
Okay.
and then I would go ahead with upfront surgery, sir, followed by radiotherapy for the neck, sir.
So, when you will not go for upfront surgery?
Sir, I will not go for upfront surgery when there is involvement of the infratemporal fossa, sir, when there is involvement of the apex of the orbit, sir, and when there is involvement of retropharyngeal lymph nodes on imaging.
These are the cases where
Yes, sir.
an MRI is extremely important.
Yes, sir.
There are nerves which are going through this tumor when it goes out of the boundary of maxilla.
Yes, sir.
So on CT scan, you may not find the perineural invasion, which will be very evident on MRI.
Yes, sir.
Infraorbital nerve can have a perineural invasion going through up to the brain. There can be a branches of trigeminal which can have a perineural invasion going to foramen ovale, and all these kind of things are missed on just CT scan with contrast.
Yes, sir.
So whenever the tumor goes out of the boundary of maxilla, an
Yes.
MRI is a must.
Yes, sir.
Okay, to plan your surgery. Now, if whatever situations you said you will not operate, what will you do?
Sir, in case I am not operating, I might consider chemoradiotherapy, sir.
So, chemoradiotherapy will not cure this patient.
Yes, sir.
It will make him worse.
Sir, I might
What
consider
you are supposed to do? What you are
neoadjuvant.
supposed to do, your multidisciplinary tumor board will
Yes, sir.
guide you to give neoadjuvant chemotherapy, which is the important step in today's time
Yes,
for
sir.
borderline operable head and neck squamous cell cancers.
Yes, sir.
Okay, and there are literature evidences which has proved that neoadjuvant chemotherapy can make them operable. Not all of them, but about 40% of them can become operable. And then
Yes.
you can operate and then give chemoradiation as an adjuvant, which can be the best line of management for them for an optimum outcome.
Yes, sir.
Okay, what kind of reconstruction will you do in these kind of patients?
Sir, in this particular patient, there no reconstruction was done. There's just an obturator was placed, sir. But I might consider doing a PMMC or a forearm flap, sir, radial forearm flap, sir.
So ideal reconstruction will be free microvascular fibula or free microvascular scapula flap, which
Yes, sir.
will give him a bony reconstruction on which there can be given implants at a later date.
Yes, sir.
Right? Pectoralis major will not reach here without you removing the mandible, which is a wrong thing to do because his mandible is absolutely normal.
Yes, sir.
So obturator versus free microvascular flap reconstruction.
Yes, sir.
Okay, these are the two options.
Yes, sir.
Before surgery, you must counsel these patients about what? How you will counsel this patient when you will say that I am going to do surgery on you? What are the things you will counsel?
Sir, post-operatively, he might have a recurrence, sir. Any?
So you divide your counseling into three things.
Yes,
One
sir.
is perioperative issues,
Yes, sir.
another is short-term post-operative, and second is long-term post-operative issues.
Yes, sir.
Recurrence will come into long-term post-operative issues.
Yes, sir.
Okay.
Yes, sir.
What are the important counseling points? This patient will have a change in voice
Yes, sir.
and issues with swallowing, possibly. These
Yes, sir.
two things you must counsel them before taking them for surgery.
Yes, sir.
Okay. The
Yes.
extent of these difficulties will depend on extent of surgery and the
Yes.
kind of reconstruction you are doing.
Yes, sir.
It's open for other examiners to ask.
Raj Gopal.
Yes, sir.
What is field cancerization?
Sir, field cancerization, genetic and epigenetic modifications in oral malignancy due to repeated exposure to carcinogens can lead to synchronous and metachronous primaries, sir.
What is synchronous and what is metachronous?
Synchronous is when second primary is diagnosed within 6 months of the first primary, and metachronous is when the second lesion is diagnosed after 6 months of the diagnosing the first primary.
What is the difference between second primary and recurrence? How will you define? So that is an important thing to define whether the patient has a recurrence or he has a second primary.
Yes, sir.
It is at the edge of the previous surgery or not, right?
Yes, sir.
Your flap mucosal junction, whether it is in the deep at the site of previous resection or not,
Yes, sir.
is whether it is a different subsite.
Yes,
If
sir.
the tumor has more than 1 centimeter margin between the two tumors,
Yes, sir.
then it is not a recurrence, it is a second primary.
Yes,
And
sir.
even in synchronous primaries, you must know that there can be a submucosal tumor extending to that supposedly second primary synchronous. So
Yes,
you
sir.
must have an MRI which can show you a submucosal tumor going to that another ulcer, and it can be only one malignancy which is presenting at two separate ulcers.
Yes.
And Rajgopal, what is this incision?
Sir, it is a modified Weber-Ferguson incision, sir.
So can you describe this incision?
Yes, sir. So, sir, the incision is big. Starts at the in the mucosal surface along the gingivo labial sulcus, and then it is continued the lip split, and then uh, around the nasolabial fold and around the infraorbital part, sir.
So the incision goes to nasal subunits. Okay,
Yes, yes, sir.
it goes around the nasal ala.
Yes, sir.
It takes a turn
Yes, sir.
Oral
and
cancer,
goes up to the
normative,
medial angle of the eye.
normative.
And there are two different extensions according to the disease. One is infraorbital extension.
Yes, sir.
Another is a Lynch extension which goes to the supraorbital area towards the upper eyebrow.
Yes, sir.
So it depends on whether you need to take out the eyeball or not. Depending
Yes,
on that, these extensions are done.
yes,
So
sir.
in this case, there can be an infraorbital extension which is at the lower lead,
Yes, sir.
right?
Yes, sir.
Okay. Do we have still have time?
Yes, sir. Hello.
Yeah. So what are the types of neck dissection? Will you do a neck dissection in this case?
Sir, patient, since it is a large primary, T4 a patient might benefit from elective neck dissections. Supraomohyoid neck dissection might benefit the patient, sir.
So don't use might.
Yes,
Now in today's time,
yes,
there
sir.
is a strong randomized controlled trial from Indian subcontinents which has published in NEJM,
Yes,
and
sir.
in today's time any T4 cancer, squamous cancer of oral cavity
Yes, sir.
must have at least an elective supraomohyoid neck dissection.
Yes, sir.
Okay, it is a
Yes,
must now.
yes, sir.
So this is a T4 cancer. You should have a supraomohyoid neck dissection even if the patient is N0.
Yes, sir.
So which are the levels you will remove?
Level 1, 2, 3, sir.
And what is level 6?
Level 6 would be pre and paratracheal, sir.
It will be prelaryngeal, pretracheal, and paratracheal lymph
Yes,
nodes.
yes, sir.
Okay. Yeah. What is 2A and 2B?
2A submandibular group of sorry, sir.
Submandibular group of lymph node is 1B,
Sorry. The upper jugular group of lymph nodes, sir.
which is 2A and 2B. What is the difference between 2A and 2B?
Jugulodigastric and jugulo-omohyoid, sir.
No. So any lymph node which is anterior to spinal accessory nerve at level 2 are
Yes, sir.
2A. The
Yes,
nodes posterior to spinal accessory are 2B.
yes, sir.
Okay.
Yes, sir.
The nomenclature of jugulodigastric lymph node is now out.
Yes, sir.
Whenever you describe the lymph nodes in the neck, you have to mention the levels.
Yes, sir.
Okay, and you must read about all these 5 levels.
Yes, sir.
What is 5A, 5B, what is 2A, 2B, what is 1A, 1B.
Yes, sir.
Okay, you must know that.
Yes, sir.
Okay.
Hello. Rajgopal,
Yes, sir.
what is commander's operation?
Commander's operation is a composite resection of the primary lesion with the segment of the mandible and neck dissection, sir. And sir, in the same incision, sir.
Combined mandible and neck dissection.
Yes, sir.
What are different incisions used for neck dissection? And what are the advantage and disadvantage of this?
Sir, so- sorry,
What
sir.
are the types of maxillectomies?
Maxillectomy may be partial or a total maxillectomy, sir.
What is partial maxillectomy known
Partial
as?
maxillectomy, it may be infrastructural or suprastructural in reference to the Hongren's line, sir. It might be a medial maxillectomy also, sir.
Right. I think there is a message, and we need to end this session. So
Yes.
thank you very much, and Rajgopal, you need to read a lot regarding neck.
Yes,
Your
sir.
answers for the primary tumor were good,
Yes,
but
sir.
you need to read a lot about neck. Neck incisions, which sir asked you, is a
Yes.
very important basic question. You must
Yes.
know this.
Yes, sir.
Okay? Yeah,
Yes, sir.
fine.
Thank you.
ತಿನ್ಮುಗಿಸ್ತೀಯ ಬೇಗ ಬುಕ್ಕೆತ್ತು ಬಿಸಾಕ್ಬಿಡ್ತೀನಿ.
I think we can start the next case, sir.
Hello. Hello, I'm Sharvari.
Yeah,
Hello,
please.
Aditya is there? Is Aditya there?
Yes, ma'am.
Yes. So, hi Aditya.
Good evening, ma'am.
Good evening. All the best. You will be starting with the next case, right?
Yes, ma'am.
Kalai, Dr. Kalai, you are there?
Yes, sir. Okay. Actually, I'm traveling back from Bangalore.
Okay.
A cab. So I'll be just I'll keep my video off because there's
Okay.
background.
So,
Otherwise, I'll be there for the case.
Dr. Nag, you are there?
Yes, Dr. Sharvari, hi.
Hi. So, should we start? We'll start.
Yes, please.
Yes. So Aditya, you can start sharing your screen. And who else is there?
Is it seen, ma'am?
Yes, yes. Yes, please start.
Good evening, everyone. I'm Dr. Aditya Jirke, third year junior resident from Kasturba Medical College. My guides are Dr. Rajgopal Shenoy sir and Dr. Bharat sir, and our HOD is Dr. Prasad sir. This is a 72-year-old male, farmer by occupation from Shimoga, who's a hypertensive since 3 years. He presented with the complaints of generalized itching since 3 months, yellowish discoloration of eyes since 2 months, and high colored urine and pale colored stool since 2 months. History of presenting illness. Uh, the patient was apparently normal 3 months ago when he developed generalized itching, which was insidious in onset, gradually progressive in nature. It is not relieved on taking medications, and the itching disturbed his sleep.
या तो
His
प्लेट
daughter,
अंदर रखो
his daughter noticed yellowish discoloration of his eyes 2 months ago, which has gradually increased in intensity to the current state, and has not subsided during this time. And there is no fluctuation in the jaundice. This is associated with passage of high-colored urine and pale-colored stools since 2 months. It is not associated with bleeding per rectum. He also complains of loss of weight, which is not documented, but he has noticed loosening of clothes since around 3 months. There are no complaints of pain abdomen, fever, or distension of the abdomen. No complaints of hematemesis or melena. No vomiting, loss of appetite. No complaints of breathlessness, cough, hemoptysis, or similar complaints in the past. He underwent an MRI scan outside and came to our hospital for further management.
Okay. So, okay, continue with the history.
Yes, ma'am. Past history, he is a known case of hypertension since 3 years on regular medications. He has undergone open appendectomy 4 years ago. No other history of hospitalization. He smokes one cut BD, that is 20 BDs per day for the past 50 years, and history of alcohol consumption, brandy around 180 ml per day for 20 years, and he has stopped 10 years ago. No history of blood transfusion in the past. Personal history, he consumes a mixed diet. Appetite is normal. The sleep is disturbed due to itching, and bowel and bladder habits are normal. Family history, there is no history of similar complaints in other family members. No history of malignancies in family members. Summary, this is a patient who's a 72-year-old male, hypertensive, came with complaints of generalized itching since 3 months and painless progressive jaundice since 2 months, which is associated with loss of weight.
Okay, so after this history, what comes to your mind?
Ma'am, the patient has painless progressive jaundice, and it is associated with loss of weight. So it is indicative of obstructive jaundice, probably due to an malignant etiology.
Okay, so why do you say it is a malignant etiology? Why jaundice?
One, because the jaundice is progressively increasing. It is painless, and it is associated with loss of weight. These points.
Dr. Aditya.
Yes, sir.
Can there be malignant jaundice, obstructive jaundice, which is painful?
Yes, sir. Carcinoma of the gallbladder can have painful jaundice. Then
Dr. Aditya, what is the relevance of alcohol intake and smoking?
Sir, may I just finish the question, please?
Okay.
So, right. So there can be even CA head of pancreas can be painful, and if there is CA gallbladder with stones or any obstructive jaundice because of periampullary carcinoma or CA head of pancreas with gallstones, so you can have obstructive jaundice with pain.
Yes, sir.
Right.
Yes,
so just don't say that because it's a painless, it's malignant. Okay.
Yes, sir.
Dr. Aditya, what is the relevance of alcohol intake?
Sir, chronic alcohol intake can lead to chronic liver disease. So So that is more in the direction of chronic alcohol intake is more in the direction of malignancy of the gallbladder or hepatocellular carcinoma. But smoking is more indicative of a malignancy in the pancreas.
Cirrhosis can also cause painless jaundice.
Sir?
Cirrhosis can also cause painless jaundice. Weight loss.
Yes, sir.
So,
Okay,
sir,
I'm not considering that.
differentiate this medical jaundice from obstructive jaundice.
Yes, ma'am.
What are the points against and favor?
Yes, sir. In obstructive jaundice, the patient will have high colored urine and pale colored stools, but that won't be.
So tell me, just for the sake of, you should be knowing the answers of this, why there is high colored urine?
High colored urine is because of the increased bilirubin that gives the high color to the urine and
bilirubin?
absence of
Excuse me.
Precise.
It's not
Is it
bilirubin.
bilirubin?
High colored urine is because of absence of urobilinogen and
Absence of urobilinogen
and increased bilirubin.
For 2 minutes, think for a few seconds and then give the answer precisely. Why there is high colored urine? Simple question.
Yes, ma'am. There is increased direct conjugated bilirubin. So,
okay.
So since there is increased conjugated bilirubin and in the gut there is no formation of urobilinogen.
Urobilinogen.
And once it is filled.
Urine.
No, hang on.
You are consuming it with feces. Okay. So
let us revise the bilirubin metabolism.
Sir, the conjugated bilirubin from the liver through the biliary duct, it once stored in the gallbladder, then passed through the common bile duct into the gut. So
okay,
once
there is obstructive jaundice, so there is no passage of bilirubin. So
yes.
be quick.
So because of the backflow, the conjugated bilirubin itself is thrown into the bloodstream, and because of that, there is no oxidation of this conjugated bilirubin to form.
Have you heard what passes through kidneys?
In the normal state.
Urobilinogen.
Urobilinogen.
Yes. So the urine color is because of urobilinogen?
Yes, ma'am.
No.
The high colored urine.
Look. It says conjugated bilirubin is water soluble.
Yes.
Right. So it comes out in the kidneys. Comes out to the kidneys. So you have increased bilirubin. You have got bilirubin urea.
Yes.
Right.
Yes.
There's no question. Don't bring urobilinogen here. Yes. Urobilinogen happens when it goes into the feces, into the gut. It is changed from bilirubin to stercobilinogen and absorbed as urobilinogen and then comes down.
Yes.
Right.
Yes.
See, in fact, the urobilinogen absence.
Yes.
Yes, can I go on?
Okay, so one point which differentiates the. Okay, so if it is, for example,
self-study. See, I'm also doing self-study. Maybe class attend kar raha hu.
Okay, let's go to your first slide, Aditya. Let's go to your first slide. Right. You said it is obstructive malignant jaundice because of malignant origin, right? What kind of can you, by your history, find out what kind of malignancy is this?
Sir, yes, because the progressive jaundice is indicative of carcinoma head of the pancreas.
We've it that you think it's a malignant jaundice.
Yes, sir.
Because of malignancy.
Yes, sir.
Now, what are the malignancies which can cause this kind of obstructive jaundice?
Sir, carcinoma head of the pancreas, cholangiocarcinoma.
You see, just say periampullary carcinoma with carcinoma head of pancreas. Okay?
Periampullary carcinoma.
Someone should mute Mr. Zawami.
Please mute pure this thing. Everybody should mute.
Mr. Zawami, please mute yourselves. M2. Right. Okay. Hello.
Yes, sir.
Right. So you have four things. You have CA gallbladder, you have the cholangio, you have the ampulla of Waiter, and you have the CA duodenum and CA head of pancreas. Five things.
Yes, sir.
Well, your patient fits in which of these?
Sir, he fits in CA head of pancreas, carcinoma of the ampulla.
No,
and,
you can't. You can't. Okay. CA head of pancreas is characterized by what? What were the complaints of the patient in CA head of pancreas usually? When there is jaundice, what does Philly complain of?
Sir, there will be progressive jaundice.
That in all of them, there will be progressive jaundice.
Yes, sir.
What else does the patient complain of?
See, Aditya, our first thing was to differentiate it between hepatitis, medical hepatitis jaundice, and obstructive jaundice, right? So we agreed that now it is surgical jaundice.
Yes.
Now we have to at least think of what can be the location. Here also we have discussed about painful jaundice and painless jaundice.
Yes.
So now tell us about out of these 3-4 diagnoses, which are the painful and which are the painless?
Painful are carcinoma of the gallbladder and
Okay.
carcinoma head of the pancreas.
That's it. So out of these 4 or 5, these 2 will be painful.
Yes.
So what will be painless?
Painless will be cholangiocarcinoma.
Aditya, what are the most common cause of painful jaundice?
So let's him answer once, then we will go to your question, please. Let him finish the answer, please, sir.
That is the same question, sir. It is combined.
Sir,
painless
jaundice will be periampullary carcinoma,
That's it.
cholangiocarcinoma.
Okay, periampullary includes four carcinomas, right? So it is periampullary. So sir, to answer sir's question, because your patient has a painless progressive jaundice, thinking in terms of
periampullary carcinoma.
Bus, that's it. You can say only this much.
Yes,
and although with this, I will like to keep other possibilities also in mind, because
yes.
you cannot be sure at this stage.
Yes.
Okay. Now CA duodenum. What is the characteristic presentation of a patient with CA duodenum?
Sir, one will be, because it is growth infiltrating into the duodenal lumen, there can be
growth infiltrating. CA duodenum means CA duodenum infiltrating into what? CA duodenum is CA duodenum.
Yes, there will be vomiting, gastric outlet obstruction.
Okay, not very likely unless very large. Before that, what will the patient present with?
Sir, pain abdomen and vomiting.
Melena and hematemesis is very common. They'll present with that.
Yes.
Right. What about the ampulla of Waiter? How do they present?
They'll have waxing and waning type of jaundice.
Right.
And
will there be melena in patients with obstructive jaundice?
Yes, sir. There can be melena.
How you can have melena in a patient with obstructive jaundice?
Sir, if the tumor is a periampullary type and it is growing beyond the limit of its blood supply, that part of the tumor gets necrosed and sloughed off.
Raj, once it has been said, go and study yourself.
Okay.
So,
usually, what is the size of the tumor which when it sloughs off?
Size of the tumor.
Exam हो या ना हो, revise करते रहेगा तो दिमाग में जाता रहेगा. Do some maths, some four sums you do every day.
Hello, Mr. Dr. Zaumi, whoever it is, please. Hello.
तो कुछ और हिंदी
mute yourself. Yeah, go on.
Go.
Sir, I'm not sure about the size beyond which.
Sir, I think Aditya, regarding the melena, you should be clear.
होता है.
Yes, sir.
जाओ एक चैप्टर हिंदी पढ़ लो.
I think there's some. See, the black color in melena is due to stercobilin, right? Hello.
Yes, sir.
See, because there is no bilirubin, there is no stercobilin formation. You won't have typical melanin patient with obstructive jaundice. So, what is the typical? You haven't heard about the silver color stool?
beaten. Yes, sir. Silver beaten stools appearance.
So that is the typical appearance in a patient with bleeding. They don't have melena.
Yes, sir.
No, I think that's wrong. Melena can happen even if there is obstructive jaundice, because all the bacteria doesn't go away. There'll be acid hemetin forming, and the bacteria will still act on it. So you can still have melena in a patient with if there is obstructive jaundice.
Yes,
all
sir.
obstructive, right? Okay.
This is your last episode.
Please continue, ma'am.
Yes, now we have.
अभी एक और देख रहे हो बस. Only 2 for you.
So Aditya.
Yes, ma'am.
Okay, so now I think we have reached to that end of the history, and we have come to the conclusion it might be a periampullary, right?
Yes, ma'am.
Okay, so can you define just quickly what is periampullary carcinoma?
Periampullary carcinoma is a tumor within 2 centimeter radius of the ampulla of Vater.
Okay,
which can include medial 1/3 of the head of the pancreas, ampulla of the Vater, the distal CBD, and the duodenum surrounding the ampulla.
Okay, so with this patient of this obstructive jaundice with this periampullary lesion, what is the in the presenting complaint or in the negative history you will most commonly ask about clinically to know the patient's clinical status in the history? What are you worried about?
Cholangitis.
Exactly, very good. So this should be your first negative history.
Yes.
So what will you ask?
For cholangitis, pain, abdomen, and fever is something that I want to know about, along with the jaundice.
Okay, so you will ask the history which excludes other diagnosis which comes to your location and the complications of the disease, right?
Yes,
so proceed with the next part of the case presentation.
Yes, ma'am. General physical examination. The patient was examined in a well-lit room after taking consent. He is conscious, cooperative, oriented to time, place, and person. ECOG status is 0. Height is 170 centimeters. Weight 64 kgs. BMI 22.1 kg per meter square. Pulse is 64 beats per minute in right radial artery. Regular rhythm, good volume. Blood pressure 130 by 80 mmHg in the right brachial artery, sitting position. Respiratory
Pulse
rate
is 64. Hello. Pulse is 64. You are okay with this? You expect this, or it?
Ma'am, it's slightly towards the lower side.
Again, back to physiology. Is it okay?
Yes. You would expect for this patient to have around 70 to 80 range.
Why?
One is his old age and
old age. No.
No,
This so there can be some reason.
Yes, ma'am. The low pulse rate can be attributed to the jaundice itself. The bile
Very
salts
good.
getting sedimented in the dermal layer, causing activation of the mast cells, which releases histamine. Sorry, that causes itching. But it's because it acts directly on the SA node and bile salts.
Okay. Bile salts, I have not asked you the etiology at all. I am just asking you whether it is expected.
It is expected.
Jaundice patients can have bradycardia.
Yes, ma'am. It is expected.
Okay. And then you go and read about why it is so.
Yes.
like the bilirubin, high colored urine and pale colored stool. Also read about this. What is the effect of bilirubin on heart?
Yes, ma'am. He's afebrile. He has icterus, no pallor, cyanosis, clubbing, generalized lymphadenopathy or edema.
Icterus. Let us wait on icterus. Why icterus is there?
Ma'am, the icterus, in this case, because it is noticed in the sclera. The sclera
Why?
contains elastin, which is more, the bile salts are more, they get attached to the
Affinity towards this.
affinity to the
Okay,
elastin.
so where looking at the patient, if the patient has icterus, what can be the bilirubin level?
Ma'am, around
Can you roughly
2.5
tell?
2.5
Very good. If
mg
it is
per
more
day.
than 2.5, icterus appears. Where all you can see for icterus other than the sclera?
Frenulum of the tongue. Yes,
Okay.
base of.
Oh, okay.
Then palms and soles, abdominal wall.
More in the oral cavity.
The palate, man. In the soft palate region.
Okay. When it will be seen on the palms and soles?
Palms and soles, it will usually be when it's high bilirubin, around 10.
Yes, more than 7 or 8, then you will be seen. Okay. So proceed.
Yes, ma'am. Head to toe examination.
These are actually MBBS. Even you can know you might be knowing this since MBBS, but at this stage you must be knowing all these things.
Head to toe examination. Scratch marks are present over bilateral upper and lower limbs and abdomen. Icterus is present.
Very
No
good.
signs of liver cell failure are known.
Okay, so again one basic thing where you should have noticed it in the history. Itching appears first or icterus appears first?
The icterus.
Sure. What is the very first symptom of the obstructive jaundice?
They'll have itching.
Yes. But depending upon the location also, that the sequence of the symptoms might change. Okay, let us discuss it later on. You will proceed with that.
Yes, sir.
What signs of liver failure look for?
Sir, signs of liver cell failure like icterus, then engorged veins in the chest, then ascites, and then loss of axillary and pubic hair, testicular atrophy, bilateral parotid gland enlargement, and flapping tremors.
Okay, move in.
Per abdomen examination, on inspection, the abdomen appears flat. Fullness is noted in the right hypochondriac region. On head rising test, the fullness is not visible. Umbilicus is central in position and inverted. Oblique scar of 7 centimeters present in the right iliac fossa, appendectomy scar, which is healed well by primary intention. Scratch marks are present in bilateral lumbar and iliac region.
Scratch marks of what you want to say?
Scratch marks it was seen in the lumbar region and iliac region.
Because of what?
This is because of jaundice.
Where most commonly you will look for scratch marks?
Ma'am, in the lumbar region.
Which region, which body part will have itching most? Which time of the day will have itching more? That was there in the history actually.
Which part of the day?
Which part of the day means day, evening, morning, night?
Evening time it will be more.
You said in the history, na, it disturbs sleep. Was it there in the history?
Yes,
every history, every part has its significance.
Yes, ma'am.
And which body part?
Ma'am, in the limbs, upper limbs, he'll have more itching.
Yes, so the extremities, upper limbs and on the
And
legs.
lower legs, yes.
Okay.
No engorged or dilated veins, no impulse at the hernial orifices, no flank fullness, external genitalia appears normal. On palpation, the abdomen is soft, non-tender. A globular mass of 7 into 5 centimeters is palpable in the right hypochondriac region, below the right costal margin, extending medially 8 centimeters from the midline, inferiorly 7 centimeters below the right costal margin along the midclavicular line, and laterally 3 centimeters lateral to the right midclavicular line. The superior border is not palpable. The surface is smooth, firm in consistency, and restricted side-to-side mobility is present. The mass moves with respiration. It is intra-abdominal and intraperitoneal. No other mass is palpable in the abdomen. All the hernial sites are normal on palpation. Percussion, a dull note is heard over the mass. Liver span is 13 centimeters along the midclavicular line. No free fluid is noted. On auscultation, normal bowel sounds are heard and no bruit is heard over the mass. Per rectal examination, the sphincter tone is normal. Pale stool staining on the glove. No mass or nodule is palpable. Left supraclavicular fossa is no palpable lymph node. The other systems, respiratory systems, bilateral normal vesicular breath sounds are heard, no added sounds. Cardiovascular system, S1 and S2 are heard, no murmurs. Central nervous system, the higher mental functions are intact. GCS is 15 by. Summary, 72-year hypertensive male came with complaints of generalized itching since 3 months, painless progressive jaundice since 2 months, associated with loss of weight. 7 into 5 centimeter mass in the right hypochondriac region, moves with respiration and restricted mobility, likely palpable gallbladder.
Okay, so now you have only one additional finding, that is palpable gallbladder.
Yes, ma'am.
Okay, so what does it interpret?
A palpable gallbladder in the picture of jaundice indicates that it is more likely, not likely due to a gallstone and more likely due to an malignant etiology.
Okay, that is one thing that you are what you are telling is the interpretation of
Courvoisier's law.
Courvoisier's law. What is Courvoisier's law?
Courvoisier's law is when there is a palpable gallbladder with jaundice.
No. What is Courvoisier's law?
In the picture of jaundice, when the gallbladder is palpable,
patient.
It is unlikely due to gallstones and
yes, palpable gallbladder is unlikely due to gallstones. Okay, so that is one interpretation, that it can be it may not be because of gallstone. What next in significant interpretation you get from palpable gallbladder?
One is there is obstruction distal to the cystic duct joining into the pulmonary.
Yes. So it again favors your provisional diagnosis of location of obstruction, location of site of obstruction.
Yes, ma'am.
Right. So
yes,
if the gallbladder would not, what is the fallacies of Courvoisier's law?
Ma'am, in case of if there's a mucosoil or empyema of the gallbladder, or if there's a double impacted stone, a stone in the CBD and the cystic duct, or if there's a pancreatic stone obstructing the ampulla, in these cases also the gallbladder can be palpable.
Okay. So now you have examined the patient and there is palpable gallbladder with your diagnosis, provisional diagnosis of periampullary. So how would you like to
Am I audible?
Yes.
Yeah, just one comment, because see, we all were taught as Courvoisier law. I mean, because this is what you will be asking exam also. But one thing if you actually see the original description, it was never stated as a law. It is actually a sign. It is based on some around 163 cases in which he has found that in patient with stone, the gallbladder was not palpable, whereas in malignancy, it was palpable. So actually, it is not like something like Newton's first law, second law. It is never stated as a law. It is actually a sign. So that's why exceptions to Corvusel law may not be the right. I mean, but you will be asked this question in the exam many times. This is how we were taught. But actually, if you read the original description of Corvusel, it is actually described as a sign. I mean, just for understanding, you can just keep that in mind. But I mean, it will be happening. Like you might be asked in the exam also as a law.
Yes, sir.
Aditya,
Yes, sir.
what about the dull note or the swelling is continuous with liver dullness, or
Sir, it
you are
is
not
continuous.
it is continuous?
Yes, sir.
Okay.
So, diagnosis, the patient has obstructive jaundice with a palpable gallbladder, most likely of malignant etiology. My differential diagnosis will be periampullary carcinoma and head of pancreas.
What are the point to say it is periampullary carcinoma? What are the point to say it is due to head of pancreas?
So, periampullary carcinoma because since it's in the beyond the cystic duct because of the palpable gallbladder and progressive jaundice. This is more indicative of periampullary carcinoma.
Okay, so how would you like to confirm or reach to a definitive diagnosis?
To confirm to reach a definitive diagnosis, I would like to do CECT abdomen and pelvis. First, I would do an ultrasound of the abdomen and pelvis. But to find the mass lesion itself, CECT abdomen and pelvis will be helpful.
It will be always seen on CCT or on USG?
Not always. On USG, it is definitely harder because of the obscuring bowel gas shadows.
Okay, so what is the purpose of your investigation? Say USG. What is the purpose of getting USG done?
Yes, ma'am. With ultrasound, I would like to see the.
So you are not now looking for mass because it may not be seen.
Yes.
Okay, so
With
then
the
what is the
with the ultrasound, I would like to see the dilatation of the CBD and the intrahepatic biliary radical dilatation. And of course, the status of the gallbladder and if there are any gallstones. And if there are any prominent lymph nodes at the porta hepatis. These will be shown on the ultrasound. But the retroduodenal part and the infraduodenal part of the CBD are more better visualized, not that visualized on ultrasound.
Okay, and on CT, so what other information you will get on CT? Why
on
you
CT,
want to see?
On CT, I will I will see the dilatation extent. Plus, I will see the mass lesion if it is.
Dilatation extent, you said it on USG also. You want to see till what periphery level the ducts are dilated?
Till the ampulla.
So in better terms, what do you want to really look for?
Visualize the retroduodenal and infraduodenal part of the CBD.
You want to look for CBD. CBD will be seen, and especially if there is the lesion, it will be seen.
If there is a lesion, I like to see the size of the lesion, extent of the lesion, and if there is any infiltration in the surrounding structures. This will help us with the, if we are planning a surgery, it will help us with the resection.
Would like to confirm that it is obstructive jaundice because there is CBD dilatation, presence of IHBRD.
Yes.
You would like to see the level of cutoff.
Yes, ma'am.
Level of obstruction.
Yes.
You may not see the lesion, but you will see the what level is obstructed.
Yes,
okay. You will see the is there any other mass? You will see the status of liver. You will look for the metastasis. Is there any lesion?
Yes, metastasis.
You will look for the ascites.
Yes.
All these things you will look for in the USG itself.
Yes, ma'am.
Right. And in the CT now, what you are looking at? First of all, how will you tell your radiologist what CT you want?
We want pancreatic protocol, CCT, abdomen and pelvis.
Very good. So what pancreatic protocol, CCT?
Pancreatic protocol is we get 3 mm slices of the CT scan, where it is basically split into 4 stages. The first stage is the scout image, which is without any contrast. Then once we inject the contrast, we get images in the arterial phase, which is between the time period of 10 to 30 seconds. And then we get a portovenous.
Big timing.
Huh?
Is it 10 to 30 seconds?
Ideally less than 10 seconds, but the allowed window is up to 30 seconds.
Okay. You want early arterial or delayed arterial?
Early arterial.
Okay, continue next.
Then portovenous phase from 45 to 90 seconds. And then a delayed phase, which is at the 3-minute mark. So these are the 4 stages we get.
What contrast, how much contrast, at what rate the contrast should go? What is the amount of contrast? Amount in ml. At what rate? So much ml per minute.
Not sure about the
okay.
amount of.
Okay. So you
actually you see the pancreas in which phase, and in which phase you see the lesions nicely in a pancreatic protocol CT?
Pancreatic mass is more well seen on portovenous phase, sir.
No. See, there are two critical. Okay, there is a pancreatic enhancement phase in which the normal pancreas enhance and the mass lesion appears hypotense. The portal venous phase is mainly to look for liver metastasis. Okay, so that's a key part of pancreatic protocol CT. In addition to what I mentioned, the late arterial in which the pancreas enhances nicely. You add an early arterial only for looking the neuroendocrine tumors. If you have pancreatic neuroendocrine tumors, they are seen in early arterial. Otherwise, in the late arterial, which is actually called as the pancreatic parenchyma phase, the lesion will appear hypodense compared to the normal pancreas.
Yes, sir.
You got it. So
yes, ma'am.
We need to take 2 to 3 mm cuts in order to see the small lesion and infiltration.
Yes, sir.
This one more additional point.
Continue. Yes, then we get the pancreatic protocol, CCT, abdomen and pelvis, and thorax also to check for distant metastasis.
So now in pancreatic protocol CT, points in USG, I told you what all points you look for USG. So obviously those will be confirmed on CT.
Yes.
Other than that, what you will find on CT more?
Ma'am, if there is a mass detected, we will know if there is infiltration into the surrounding structures, if there is blood vessel, superior mesenteric artery or the celiac.
You are interested in looking for?
Ma'am, the superior mesenteric artery and vein. The
vein.
Ma'am?
First of all, whether artery or vein, what will be involved, and it is a periampullary. Keep in mind that this is a periampullary lesion, right? Or you
Yes.
are talking about CA head of pancreas?
Periampullary and CA head of pancreas.
Okay.
So this basically will help us with to know if it is resectable or not resectable.
Okay. How?
Ma'am, if the tumor size is T1, T2, or T3, these lesions can be resectable because it is in the range of less than 2 centimeters, 2 to 4 centimeters, or more than 4 centimeters, but no infiltration into the vessels. If it is a T4 lesion, that means there is infiltration into the superior mesenteric vein or artery, or the common hepatic artery or vein. So depending on the abutment or encapsulation around the vein or the artery, it can be borderline resectable. And
What is
if there is
borderline resectable?
borderline resectable mainly comes in T4 lesions. So in terms of SMV, if there is less than 180 degree encapsulation, then it can be resectable. In case if there is more than 180 degree encapsulation, but reconstruction is possible, then again it is borderline. In superior mesenteric artery, if it is less than or equal to 180 degrees, it is resectable, but more than 180, it goes into unresectable. And
No,
when
why it is called as borderline resectable?
Sir, that's because there is abutment or encapsulation around the superior mesenteric vein and artery. So there are chances that um, because it is in close proximity to the vessels.
See, what you should understand is borderline resectable lesions are potentially resectable. However, the chance of R1 resection is more, and they have also chance of more recurrence. So you need to probably add multimodality therapy like neoadjuvant therapy.
Yes.
Okay,
Yes.
so that's why it is called borderline resectable. Otherwise, they are technically resectable. If something is not resectable, we use the term unresectable.
Yes, sir.
Okay. So you should know why it is called as borderline resectable.
Yes. And then unresectable is when there's more than 180 degree encapsulation around the superior mesenteric artery, or if there's involvement at the bifurcation of the portal vein, or the celiac artery involvement. So these become
Okay, so I think we have not progressed about this patient. So let us see what are the investigations of this patient.
yes,
As
the outside
we
MRI
have
just showed this abrupt distal CBD cutoff.
to MRI. If the patient would have come to you,
Ma'am,
first before getting MRI done outside,
ma'am, this was
if you would the patient,
the blood
would
investigation.
you advise MRI?
No, ma'am.
You would advise MRI?
No, no.
No.
Won't advise for an MRI scan.
Okay.
So on admission, the blood investigations, the LFT showed elevated total bilirubin of 19, direct bilirubin 16, and ALP was 408. Coagulation profile was normal. And the tumor marker CA19-9 was 824. CECT abdomen, pelvis, and thorax was done, where we can see the intrahepatic dilatation of the biliary radicals. Then as we progress down, the dilated common hepatic duct, then the dilated cystic duct and the common bile duct. This is the arterial phase, axial cut, where we can see the intrahepatic dilated biliary radicals, the distended gallbladder. And in the CCT thorax, there was a suspicious nodule in the anterior segment. The report showed gross dilatation of the common hepatic duct, central and bilobar intrahepatic biliary radicals, with abrupt cutoff in the common bile duct in a distal to the cystic duct opening, secondary to a suspicious enhancing lesion measuring 12 into 7 mm. Few enhancing nodules with feeding vessels in bilateral lobes and anterior segment, likely metastatic.
Okay. So just for our discussion purpose, let us keep this metastatic lung nodule aside for a while.
Yes,
and suppose this CT is there showing all these things without involvement of the vessels. So
yes,
what would you like to proceed? You would like with the bilirubin is how much is the bilirubin? 20, I guess, 19.9,
yes,
right?
19.9.
So what will you do? You will
First,
post the
this high bilirubin is hepatotoxic, so I would like to bring down the bilirubin. So uh,
So what
stenting,
is high bilirubin in your language?
ma'am,
How
in
much
the
is the high bilirubin?
in a
Where
picture
from?
of malignancy, ma'am, it will be more than 15.
This is your institution protocol, or you have read it, or what is the reference for this?
Ma'am, for normal bilirubin, ma'am.
No. So all the bilirubins above 15, you would like to bring down the bilirubin?
Ma'am, if we are planning surgery,
Of course, we are planning
yes,
surgery. Which surgery?
in that case, ma'am, the bilirubin this high can be hepatotoxic post-operatively.
Post-operatively.
See, just understand the question. No, it's basically the indications for pre-operative biliary drainage.
Yes.
Is the indication which you are telling is a universally accepted indication or not?
No, sir.
So why you want to do drainage in this patient?
How will you get down the bilirubin?
By doing an ERCP and placing a stent.
You want to do ERCP and place a stent?
Yes, ma'am. But if we are planning surgery, ERCP is not usually done.
We are planning surgery, na? Now this is there.
Yes,
and
in
we
that
are
case, we can do insert a side viewing endoscope and take a breast cytology. And once the malignancy is confirmed.
Okay, just tell us what is your plan.
Yes, ma'am. The plan would be to insert a side viewing endoscope and get a breast cytology. Once the malignancy is confirmed, we can proceed with surgery in this case.
Is there any doubt of malignancy still?
No doubt.
Do you think it is mandatory to get a biopsy in this patient?
And if your biopsy comes negative, what is your plan?
In that case, I would want to place the stent, sir.
So stent placement depends upon the biopsy?
No, ma'am.
You are confused?
Ma'am, if the tumor is resectable, we have to go with upfront surgery.
Now it is a third thing you are telling. First you said biopsy, then said stent, now saying surgery. Yes, you can do this, you can do that, but what will you do? Only one thing you have to choose now.
Surgery will be the choice.
Upfront surgery. Without stenting, without biopsy. Right?
Ma'am, a brush cytology is advisable before surgery.
What you usually do at your center?
Sir, in resectable masses, just surgery is done. Borderline, we plan for.
Do biopsy or you don't do biopsy? You in all patients you go ahead with surgery directly, or you do biopsy if it is positive, then okay. It will not come positive, then you explain the patient and then
No, sir.
check surgery. What you do?
Resectable mass will be upfront surgery.
Without biopsy.
Yes, sir.
Okay. What's the problem in having biopsy?
Sir, when we're introducing the scope, there is risk of cholangitis, precipitating cholangitis.
Suppose you did surgery and biopsy came negative for malignancy. When patient is saying, Doctor Sahab, आपने तो malignancy बता के operation, you did that, and now he sues you. You resected did unnecessary surgery.
Sir, it is more likely, considering the clinical picture plus the scans that we've done, it is more likely a
But
malignancy.
biopsy is available, na?
So that is simple words. Tell us what are the indications of getting biopsy.
Indications of yes, ma'am. Indications of biopsy is when it's a borderline resectable tumor, because once the biopsy is done and we confirm malignancy, we can plan for neoadjuvant chemotherapy.
Good. So
and in unresectable masses, just to confirm that it is malignancy and then proceed with palliative treatment.
Okay, very good. So now you are clear about that biopsy.
Yes.
Otherwise, biopsy is not needed in such a clear cut, if there is such a clear cut picture. Now about the preoperative biliary drainage, what are the indications for biliary drainage before Whipple's?
There is
acceptable or acceptable by everyone.
Not sure of the bilirubin.
Okay, not sure of bilirubin, but what you are sure of when you will have to do biliary
when there
drainage.
is cholangitis.
Very good. So when there is cholangitis, you have to get down the bilirubin. You have to relieve the jaundice.
Yes.
And second indication. Same as biopsy.
For when we're planning for palliative therapy.
Neoadjuvant.
Neoadjuvant.
Or any form of chemotherapy where you cannot give chemotherapy with this high bilirubin. This high bilirubin is not a contraindication for upfront surgery. Although you can say at your level that some centers consider that more than 15 bilirubin is a risk. What risks are associated with that bilirubin level?
Cholangitis and hepatotoxicity.
What is toxicity? Liver is already toxic. Liver is already obstructed. So what else we are worried about?
Derangement in the coagulation profile.
Okay, good. Derangement in the coagulation profile. Renal impairment.
Yes.
Immunity. Wound healing. Nutrition. These are the factors affected because of obstructive jaundice. So you are worried for that. So few centers consider 15 bilirubin or more than 15-20 bilirubin. The patient will be at high risk of surgery and post-op recovery. However, it is not mandatory, or high bilirubin only without cholangitis is not the indication for preoperative biliary drainage.
Yes.
Is that clear?
Yes, ma'am.
Okay. So this CA99 is 800, more than 800. What is its interpretation?
And this is more helpful in as a follow-up, ma'am. Once we intervene, we can repeat the CA99 and see if it has significantly reduced. So that helps us understand if the malignancy has been tackled.
Okay. So you are going to post this patient for Whipple's. Will you post him tomorrow? If the patient comes today and there is history of this 3 months history with this this blood picture, Will you post him immediately?
No, ma'am. He requires pre-op optimization in terms of nutrition and
So how preoperative optimization is needed? What all things are needed? Simple.
the nutritional status
Create patient here, I guess. Okay.
nutritional
But what else?
patient, and then the coagulation profile should be within the normal limit.
More important, first and foremost thing, creatinine is not shown in this picture.
Yes, ma'am. The renal function test should
So,
be normal.
hydration,
Yes, ma'am.
isn't it?
Yes, ma'am.
Okay. So hydration. Then what
Then
all you said?
coagulation profile. Then
How coagulation profile you would improve?
we can give vitamin K injections, intramuscular or IV, 10 mg for 3 days.
Hmm.
So that is for the coagulation profile.
Hmm.
And for nutritional status, the BMI should be within the normal limit, and adequate hydration, and the protein from the LFT, the total protein should be within normal limits.
This looks normal. It is 3.59. What else is missed in this picture, which would have gone down? Nutritionally. Fat soluble vitamins?
Yes, ma'am.
Because patient no bile is going down.
Yeah. Yes, ma'am.
Isn't it?
Yes.
Patient's INR is 1, na? Why
Yes,
do you
sir.
want to give vitamin K?
Sir, if it is deranged, then we'd like to give.
It is not deranged, na?
Yes, sir. In this case, it's okay. We don't.
Suppose patient's INR is deranged and patient has got cirrhosis also, then how will you improve your INR? It is not improving with vitamin K. What is the other thing you do?
Sir, FFP transfusions.
Yes.
Okay, so I see Dr. Abhay Dalvi sir has raised hand. So sir, you want to say anything? Hello.
I just want to ask this question to this student. What is his concept of treatment of any malignancy?
Concept of treatment is for R0 resection, sir.
Any malignancy. What is your concept?
Our main concept is.
I will give you a clue. It's curative, resectable, and palliative. In obstructive jaundice, what is your concept of curation or curative resection, palliative resection, and palliation? Because these people have asked you so many questions.
Yes, sir. Curative intent is when we're removing the whole tumor itself with free margins, and with that the obstructive jaundice is also relieved.
Correct. So, can you hear me?
Yes, sir.
Yeah. So let's be very clear. You talked about CT scan, lot of things which I was hearing. When will you think of a curative resection? Forget the SMV, SMA, etc., etc. we have a thing that the patient would live at least 5 years. You understand what I'm trying to say?
Yes, sir.
Yeah, good. So let us select patients who would you like to cure and palliate with chemo, radiation, etc., etc. Just explain to these people, they will become silent.
So curative. Uh, so when you're talking in terms of curative, that means we're removing the whole tumor and there is no recurrence. So that is curative. That's what.
Correct. Go ahead.
And in palliative, it's only because if there are any features.
No. Just describe to Sharwari madam what you will do to do a curative resection if it is within your CT scan report.
Sir, you mean the surgery, sir?
Yeah.
Yes, sir. Sir, in this case, Whipple's pancreaticoduodenectomy is a curative procedure.
Correct. Go ahead.
More beneficial surgery now is the pylorus preserving pancreaticoduodenectomy. And so that itself should be enough for curation for the patient.
So what she's trying to ask you is, what is your palliative resection? She's trying to ask you, what is your palliative resection?
Palliative treatment is basically to relieve the jaundice, sir.
Correct.
And then if there is any infiltration in the duodenum, then we want to place a stent there to relieve the obstruction.
Why stent? If you are going to do a hepaticojejunostomy, why can't you add a gastrojejunostomy to this?
Sir, in a picture of palliation, the patient already is probably not fit to undergo a major surgery.
You are doing a hepaticojejunostomy for palliation of jaundice and not doing a gastrojejunostomy. Gastrojejunostomy takes less than 30 minutes, even if hand sewn. Can you explain this to me?
So, but yes, sir, that is also an option to bypass the site of obstruction.
So let us get into inoperable malignancies of the pancreas and the various bypass procedures. Can you explain that to me?
Yes, sir. One is in the palliative treatment, one is to relieve the obstructive jaundice. So we are doing an ERCP and placing a metallic or a plastic stent.
I have asked you a surgical question.
About surgical bypass.
I have asked you a very surgical question where endoscopy should not come into picture.
Yes, sir. In those patients, a gastrojejunostomy can be done. A bypass.
Correct. That is one procedure which relieves gastric outlet obstruction. Second.
Yes. The hepaticojejunostomy.
Correct.
It is called a triple bypass, right? I can give you a hint.
Sharwari should be telling us about triple bypass.
Yes, sir. Gastrojejunostomy, the hepaticojejunostomy, and pancreaticojejunostomy.
Pancreaticojejunostomy?
Jejunostomy.
Jejunostomy.
No, he is right. Yeah, classical triple bypass includes pancreaticojejunostomy.
Sir, pancreatic duct
but usually it is double bypass.
I don't want to discuss with you. Thank you so much. I'm just telling you, pancreatic duct doesn't get dilated in pancreatic carcinomas. So let us, what is triple bypass? It's triple bypass. let's forget it. I just wanted to know how much this person has gained about open surgery. When I went into it, I have no objections absolutely at all in this ongoing.
Thank you, sir. So, so I think we have done. We have spent more than 1 hour. Anyone else of the senior members? Anyone else wants to ask any question or any comment?
I think we can call it a day. I think it was a brilliant.
Aditya, why you did not keep a possibility of the CA gallbladder in this patient? What was the point against that?
CA gallbladder, in a clinical picture, the patient will have pain abdomen.
Your patient had the pain abdomen.
No, sir.
Okay.
No, CA gallbladder only 70% have pain abdomen. 30% don't. Right?
Yes.
Similarly, CA head of pancreas, about 87-80% have pain abdomen. 20% don't.
Because CA gallbladder is a very common malignancy, isn't it? At least, you know,
Right.
I'm
In
not
fact, in
sure
North
about your
India,
place.
so in fact, in North India, if you have a patient, you have to start with CA gallbladder and then go down to all those next one. While in South India, it is CA head of pancreas and gallbladder right down.
Sir, in CA gallbladder, the gallbladder will be contracted. So
not necessary. You can have a lump.
Yes, sir. The patient will have history of.
What are the type of the gallbladder you get in a CA gallbladder?
Sir,
when you palpate the gallbladder in a case of CA gallbladder, what are the various types?
There will be a hard globular mass.
Always?
Not always, sir. If the gallbladder is contracted, then it won't be palpable.
No, usually if you have a lump with obstructive jaundice, it is CA head of pancreas.
Yes,
right?
sir. Yes.
Others don't usually have a lump.
Yes, sir. So
if there's a
usually in
growth
a
arising from the neck of the gallbladder is there, what will happen? Carcinoma of the neck of the gallbladder, what will happen?
I'm not sure.
There will be mucosal formation will be there.
Yes, sir.
Okay, so you will get a similar type of the lump which you get in a case of a periampullary or the carcinoma of pancreas.
Yes, sir.
So it will be, though in the case of the periampullary carcinoma, the lump which is there relatively soft, while in case of mucosal, it usually becomes tense, but it is a smooth one. It is not a hard one which is there. What is the cause of jaundice in a case of carcinoma gallbladder?
Sir, if there are localized metastasis to the lymph nodes, enlarged lymph nodes can cause obstruction to the biliary tract.
Okay.
Porta-hepatis.
Right. So metastasis of the porta-hepatis is one.
Then infiltration into the common bile. So,
when there will be infiltration, which type of the carcinoma gallbladder infiltrates into the common bile duct? Usually they're at the neck of the gallbladder. Okay, if there's a neck of the gallbladder there, it can directly infiltrate into the common bile duct.
Yes, sir.
A mass from the gallbladder may directly compress over the CBD.
Yes, sir.
Then there may be associated choledocholithiasis may be there. In how many % of cases you get the choledocholithiasis in gallbladder?
65% of
choledocholithiasis.
65 to 70%.
No, I'm not asking cholelithiasis. I'm asking choledocholithiasis. About 10% of the cases. You will get the choledocholithiasis. That may be the cause of jaundice in the case of the carcinoma gallbladder. 60 to 70% with the cholelithiasis.
Cholelithiasis.
Okay, right. Then there can be secondaries in the liver may be there.
Yes, sir.
Or there can be isolated secondary in the liver. Can you tell where there can be isolated secondary in the liver from the CA gallbladder, which can cause the jaundice?
Sir, if it's a large metastatic lesion,
Where?
uh, sir, if it's from CA gallbladder, it should involve segments 4 and 5.
But if there is a solitary metastasis in the segment 4 or 5 is there, will it cause a jaundice? Solitary metastasis. If the multiple, it is okay. Or there is porta hepatis along with that, it will be okay. Okay, if it is at the caudate lobe.
Caudate lobe.
Okay, if the metastasis is at the caudate lobe is there, then it can compress both the bile ducts, right, as well as the left one.
Bifurcation.
That can cause. So there are around 6-7 causes for the jaundice in the case of the carcinoma gallbladder. Now, what are the things you want to palliate in a patient with a carcinoma head of the pancreas? What are the things for palliation where you are not able to go for a radical operation?
Yes, sir. Palliation first is to relieve the obstructive jaundice by ARCPM.
Why you want to relieve the jaundice? The reason for that?
One is because there is risk of cholangitis, sir.
Okay, that is one. But what is the most irritating thing in the patient with
the intractable itching is basically relieved.
Itching is the most important thing.
Yes, sir.
You want to reduce that itching because that is making the patient life hell.
Symptomatic. Yes, sir.
So that is first, yeah. Then
Yes.
what else you want to palliate?
Sir, if there are signs of obstruction, then the bypass surgery that we discussed, and then chemotherapy, sir, for palliation.
No, I'm asking you, what are the things you want to palliate in a patient with a carcinoma head of pancreas? One, you said the jaundice.
Yes, sir.
And the main reason for that is the itching and the cholangitis.
Yes, sir. If
what is the
there is
second? What is the second palliation?
Yes, sir. If there is duodenal obstruction.
So that is the outlet obstruction is there.
Yes, sir.
What is the third palliation?
Sir, feeding jejunostomy.
No, palliation. Palliation for what? Is the pain.
Pain.
Okay. Big carcinoma head of the pancreas, which is infiltrating into the back in the celiac axis.
Celiac axis.
The pain is to be relieved. So what are the ways you can relieve the pain, palliate the pain? You have to do the block there. Celiac block has to be done, which can be done intraoperative or it can be done preoperative also. By the anesthetist, they can do the celiac block to take care of the pain. So these are most important three things which are there. Okay, the jaundice, the outlet obstruction, and the pain.
Yes, sir.
So what is that triple bypass which we were discussing?
Sir, gastrojejunostomy, hepaticojejunostomy, and jejunojejunostomy.
It is not hepaticojejunostomy, it is
choledochojejunostomy.
No, it is not choledocho also. It is called hepaticodocojejunostomy. You understand that? What is the difference between these two? Hepaticojejunostomy and hepaticodocojejunostomy?
Sir, it includes the extent of the hepatic duct and the common bile.
When you are working at the common hepatic duct, then that is called as hepaticodocojejunostomy.
Okay,
but if you are working at a higher level, at the right or the left hepatic duct or at the porta hepatis, then that is called the hepaticojejunostomy.
Yes.
Okay, so you are doing a hepaticodocojejunostomy.
Okay.
Can you do a cholecystojejunostomy for palliation purpose? Because hepaticodocojejunostomy is a little more technically difficult. So can you do a cholecystojejunostomy?
So that can also be considered if this is.
So when you will consider that? When you will consider, because that is relatively, technically easy operation to carry out the cholecystojejunostomy.
Sir, when there's a infiltration of the CA head of pancreas into the common hepatic duct.
No, you have to be sure that the cystic duct is patent before you go for a cholecystogenostomy.
Sir, can I come in?
If there's a proximal.
Okay, the cystic duct has to be patent.
Yes, sir.
Okay, so how can you judge at operation that the cystic duct is patent? Because you can do a cholecystectomy only then if it is patent. If it is not patent, if it is involved with the tumor or by pressed by the tumor, you cannot do that.
So intraoperative.
How can you know at operation that whether the gallbladder cystic duct is patent or not?
Intraoperative cholangiogram, sir.
Okay, you can do intraoperative cholangiogram. If you do not have the facility for that, okay, you are working at place where you don't have the facility for that.
So we can pass a T2.
You put a needle in the gallbladder. Okay, put a needle in the gallbladder. If you find the green bile, then it is patent. But if it is white bile is there, then either it is not patent or there is a white bile coming from the liver now. You understand that?
Yes.
Putting a needle in the gallbladder, if it comes out to be green,
that means it is patent and fresh bile.
Is patent. But if it is white, then there are two possibilities.
Either
there is a white bile in the circulation is there in the liver, or it is the obstructed cystic duct. So in this scenario, you put another needle in the common hepatic duct.
Yes, sir.
Okay, in the common hepatic duct, if it is green is there, but the gallbladder is white, then it is obstructed cystic duct. But if both are white, okay, putting the needle in the hepatic duct is the white bile, then probably the white bile is coming in that. Okay, so that is the type of the bile which is there, which can tell you about that, whether cystic duct is patent or not. If the cystic duct is patent, then only you can go for a cholecystogenostomy. Otherwise, you have to always go for a hepatico-docogenostomy. Okay. Right.
Dr. Kalayarasan, would you like to add any comments, sir? Kalayarasan, sir, is not here. There, sir,
No,
and
I think fine,
Shiva.
Sir.
Anything else to be added, sir? Kalay, sir? And Hidaya sir and Sarvari madam, any other points you'd like to add? Can we call a close? Any other faculty would like to give their comments?
Yes, he has done, I think, pretty well. Okay. He can go back and read about the physiology and
certainly, ma'am.
Yes, yes.
Otherwise, from the beginning,
he has the knowledge and just to refine his answers and use more of scientific words for while answering the questions.
Yes.
Perfect, sir. Perfect, sir. Well taken, sir. Well taken there.
Good, good.
So Dr. Aditya, do you have any doubts to be clarified with the faculty before we close?
No, sir. I read about all the things that are discussed here.
Yes.
Okay, please note it down. What are the faculty pointed out, and then you improve yourself by going back to the library with the books.
Yes, sir.
Thank you, ma'am. Thank you, sir.
Thank you, sir.
Thank Nishi sir, Rajiv sir, Kanna sir, and other senior faculty. Kalay sir, thank you very much. Dalvi sir, thank you very much. And other senior faculty. Rajgopal and Aditya, do well. Good luck to you. Thank you. With this, we call the session a close.